Welcome to Doctors on Call. I'm Jenna Miller. If you live with pain, you are not alone. Pain affects more Americans than diabetes, heart disease, and cancer combined. Pain attacks human body at every vulnerable target: muscles, bones, and joints. Each person and their pain are unique. The best way to manage your case could be very different from what works for someone else. Pain management is our topic tonight on Doctors on Call with our guest, Dr. Belle Razafindrabe.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from Gove County Medical Center in Quinter. Healing through caring. Blue Cross and Blue Shield of Kansas, serving approximately 950,000 Kansans in various programs. A Value Kansans Trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Russell Regional Hospital, experts, neighbors, friends.
Dr. Belle Razafindrabe earned his medical degree from Université de Madagascar and completed his residency and training in physical medicine and rehabilitation at the Loma Linda University Medical Center in California after spending a year of internal medicine internship at the same institution. Dr. Belle is certified in physical medicine and rehabilitation by the American Board of Physical Medicine and Rehabilitation. He moved to Great Bend in 2005 and is president of Pain, Spine, and Rehab PA. Give us a call at 1-800-337-4788 toll-free with your medical questions about pain management on Doctors on Call. Doctors on Call brings you information which may be useful to you when you see your own physician. I want to thank you for joining us tonight. While those first calls come in, let's go ahead and start with our own questions, Dr. Belle.
Nice to see you, Jennifer,
Yes,
tonight.
thank you so much for coming. First of all, let's talk about the difference between acute pain and chronic pain.
Acute pain, as you know, acute pain is something that's recently happened, and it's predictable. It could be nerve injury or musculoskeletal or visceral pain. Chronic pain, if the pain persisted beyond expected predictable amount of time, and it's become chronic pain. Chronic pain, it's in addition to pain, it could have a psychological aspect on it, and it's become harder to treat. So treatment as soon as possible to address not only the pain, but the psychological and the social effect of that, as well as the conditioning of the patient.
How do you assess pain?
Pain is very much important aspect of people functioning, and as you mentioned, that assessment is the number one part of evaluation of pain. Assessment starts with history. Ask about question about when it started, how did it happen, what type of pain. It could be a stinging pain, aching pain, throbbing pain, deep aches pain, and those questions is very helpful because the type of pain can help the doctor to know is this muscle related, nerve related, and so on. It could be visceral, something that happens inside your body, create a vague type of sensation that is very hard to define. And those are questions. Beside question, you move on to a physical examination, take the patient into consideration of where is the pain, do a special test for each of them. It could be a back or spine related pain, and there are some very well defined examination to take a look of the sensation of the skin. Also can check of the reflexes and see if there is a weakness or not. And with this physical examination, you can tell exactly what level of the nerve is affected. The same if there is pain in the chest walls, make sure, is it a ribs pain, closed fracture, or is it just heart-related pain? And all those questions, physical examination is just the start of that. Following those, you can see if necessary to have imaging pictures, X-ray, MRI, CT scan, depends on if it's a bone affected, if it's a spine affected, then you can see an MRI, the look of the disc, the nerve, where it comes from, and so on. And if further treatment, you can do nerve testing. Electromyography will help to define not only where the pain comes from, for how long this pain has been having, and what the effect of this on muscle, and so on. So those are just few things. If there is inflammation aspect of the pain, you can have a blood test to check those inflammatory response to the pain, and so on, and so on. There are pain that related by inflammation, even in the spine, and some are related to trauma or injury. So all of those are taken into considerations.
Okay, we are going to go to the phone lines. We've got Sarah on the line from Waukene. Hi, Sarah. Go ahead with your question for Dr. Bell tonight.
Hi, my mom has a bulged disc in her lumbar area, and she has been suffering with pain for quite some time. She's tried chiropractic and dry needling, physical therapy. Nothing seems to be working. She's even gotten on a prescription muscle relaxant, but when she gets off of it, the pain is just back. Do you have any suggestions that I could give with her?
Thank you very much for the question. Your question is not unique. We've been seeing those people on a daily basis, back pain related to disc or related to bone. I can picture here some visual aid for you. I'm sure that your mom may be in about 50s or so. Young people, the back pain is related mostly to disc bulging, and as I can see, some area of this disc can bulge and pushing at this nerve. When you get older, the disc gets thinner, and in addition to disc, this opening of the spine called the foramina is getting tight, not only by the thinning of the disc, but the arthritis and bulging up of spur cause this opening very tight. And in this case, there's combinations of ligament that really getting kinked in. So the combination of disc, bone, ligament causing this nerve to suffer. If it's just a disc bulging at younger age, we can have nowadays some tools that will help that. Those medical conservative management can be tried in physical therapy, but if the nerve actually suffered from pressure, there are options about minimally invasive treatment to trim the disc that pushing on the nerve, and there is also some treatment that will be start with just epidural steroid injection to relieve the inflammation of the nerve exit. Nowadays, we do have an option of endoscopy that will cut the bone just in front of this nerve without open surgery that will require a laminectomy or removal of the rest of the bone. The endoscopic surgery will just cut some part of the area where the foramina is with a small opening from the back, and that will help give some relief. In addition to that, there are also some options that if this spinal is so tight, there are options that will get through the opening of the back using a ranger, which is like a big spoon, and clean some of the tightness of the spine, and that will relieve some of the aspect. The most important is to have the MRI reviewed, and when you have the MRI reviewed exactly, we can really define the option and the access of the treatment for the patient. And don't be discouraged. There are always options nowadays. Medicine has been evolved and the technique has been refined, and most of the back pain, especially if it's related to pinch nerve, has some solution nowadays.
Excellent information. Now this, we had another viewer who emailed us. It sounds like it could be very similar, a very similar answer, but I'll go ahead and read the email and then you can let me know or let the viewer know. Sure. This comes from Tabitha, and she says that she currently has a herniated disc at her L5-S1 that is pushing on her nerves. She's already done and still is doing physical therapy. Sounds like Sarah's mother. She says she has had all 3 epidural shots and tried disc Decompression and a 10S unit to help with the pain. She's been dealing with this for the past 7 months. Seems to start feeling better. Then a few days later, she's right back to where she started. I don't do anything differently from when it's feeling better to when it goes back to being extremely painful. It does cause my entire right leg to go completely numb. I really wanted to avoid surgery at all costs, but it looks like that's my next step. Is there something else I could try to help with the pain? And if I end up doing surgery, what kind of recovery period am I looking at? And will surgery help? A lot of questions there for you.
Yes. Thank you for the questions. She has disc herniation at L5S1. We can tell this is a spine. This is the L5 level. And then the disc involved will be this one, where it is the S1 and L5. She has been getting epidural injection, which is a good start. You know, to alleviate the pain, it might give relief for 1 week or so, but it also can give some relief for a longer time. The key is that we need to know what type of pressure she gets from. And if it's just a simple herniation, there's 2 options. You can go into open back surgery, which is a very traditional surgery, removing this lamina, open up this facet area here, and then get some decompression of this nerve. That is open back surgery, and it depends, but the surgeon could have a fixation or hardware to stabilize that because we took some part of the bone. As I said, nowadays, the minimally invasive is very standard because the recovery is pretty quick and the treatment is pretty fast. And those can be done using endoscopy or using fluoroscopy. We call it disc decompression. We using the tools that goes through here and get into the disc and drill the disc and take some part of the disc, hopefully help. And there is also, as I said, well, there's a very minimally invasive that cut part of this bone, get access to it, and then remove the excess of the disc from the back or from the side. Depends on what type of bulging is that one. I want to mention here that from 30 old and above, the disc change is very expected. And there is some conservative management. I mentioned to patients that there is always a tendency that those disc bulging can shrink over time. The duration may not be now. It could be 5 years, maybe 10 years, but it could shrink over time and that compression gets better over time. So depends on the severity and intensity of the pain. It can treat it by physical therapy, combination of type of injection therapy or in a minimally invasive treatment.
Well, Tabitha seems to be a little bit nervous about the surgery, but from what you're saying, it sounds like it's maybe come a long ways.
Yes, as I said, there is option for minimally invasive, which could be taking about 1 or couple days of recovery, and it can be done nowadays.
Okay, excellent. Now, lower back pain is pretty common. When should a person see their doctor or be referred to you?
That is a very good question. Low back pain, everybody can expect some type of back pain. 90% of people expect 1 or 2 back pain in a year. And it can be relieved right away. But there is pain that, number one, has been debilitated in the people, receiving affected function, affecting quality of life. I've been using conservative treatment, therapy, medication, over the counter, all of that. Visit with primary care, and the primary care will probably refer patients to a more specialized. When you get into a more specialized pain management, you need to know what type of pain management is this. Is it a single specialty or is it interdisciplinary, what they could offer? And that communication is very important. Number 2, you can see a specialist of pain management or interventional pain management if there is some type of weaknesses of the area. If there is a change in bowel and bladder, those are very important. If the pain is at night, if you're elderly, we don't know, it could be some underlying cancer into the spine. There are options too for people who have been receiving high dose of anti-inflammatories that can be damaging the noble organs, and to avoid taking into extra narcotics and opioid, there are some pain that can be treated, and there's some perpetuating factor that can control to help get into chronic pain.
Okay, we want to remind our viewers that we are talking with Dr. Bell Razafindrabe from Great Bend tonight. We are discussing pain management, so if you have a question for him, you can give us a call at 800-337-4788. Now, I think it was Sarah that had mentioned the muscle relaxants. Let's talk a little bit about those and how effective those are.
Muscle relaxant is an adjuvant addition to pain. Muscle relaxants, most of them don't really know how it works. However, muscles play a big role in pain. Number one, when we have nerve affected here, this nerve is covered by muscles. And when the muscles are irritated, those muscles usually cramps. And when the muscle cramps, it squeezes the nerves. When it squeezes the nerve, makes this pain more worse. So having the muscle relax will release the nerve and then help things better. In addition to muscle relaxant, there's some stretching that can be done as well. So number two, muscle relaxant may help relax the muscle in one way, and some of time also will help people sleep at night. There's a side effect of muscle relaxant that will enable patients to sleep better. But as I said, well, don't overuse those. Sometimes that can be temptations.
They can become dependent on them.
It can become dependent. But since we are here, I would like to give some idea about what type of options that we have nowadays in pain management, especially spine-related. There are always spine-related pain, non-spine-related pain. You can talk about headache and so on. But this is a picture of spinal stimulator. People have been asking, what is spinal stimulator? Spinal stimulator is most likely we used if there is no other option to treat the pain. The pain, people, most of them had underwent multiple surgeries, developed scar tissues, and the scar tissue can be impinging on this nerve and so on, and the problems become multiple roots. Treatment become difficult, high dose of narcotic and so on and so on. So this is an option. It's not fix the problems, but this spinal stimulator can be applied and inserted just behind the spine. And when it's there, it will just block the transmission of the pain to the brain. It gets into area in the back of the spine where there is special cells there that can be activated and will block the pain. And people really will relieve. Nowadays, the new spinal stimulator is very effective. Not only the pain travels to the leg, but it can also control the pain that is around the back. That is spinal stimulator. There are people who are, especially elderly, who maybe just get and say, hey, wow, I just opened the window and had so much severe pain. Or I just pick something on the ground and have so much severe pain. This type of pain, I can tell you, they cannot move, they sleep in pain, and they cannot have appetite, and the life of this elderly can deteriorate really overnight or things. And it can become from fracture of the spine. The spine, as you get older, look at this. This is kind of dense, pretty okay, but as we, especially in the elderly lady, this spine can be changed into a porous, like this, and then it can be very easy fractured with bending and so on. It's called compression fracture. When you have that compression fracture, it can be painful, and people may have 1, 2, 3 compression fractures. And this we call kyphoplasty, is a way that inserted a balloon inside the spine. We can create a cavity, get the this is a type of instrument that will insert it through the facet into the area where the spine is broken and compressed, and this small balloon can be inflated there and not only help restore the height, but create a cavities. When the cavity is created, we can pull the balloon and insert the cement in there. And that cement will just contain the fracture and block the bleeding and instantaneously relieve the pain. And so the benefit of that will be really good because there's no way of doing those in the past, but people can change their quality of life. That we call it kyphoplasty. We mentioned about spinal stimulator. We talked about discectomy, which help the disc bulging. But this is another option here called minimally invasive spinal decompressions. In the past, there are people, especially elderly, who have tight spine. And when they have tight spine, the balance is not there. It can be falling. Not only the balance, but they cannot control their leg. Not only painful, but after distance for a while, they're just losing that strength, and then they're looking for a chair to sit. If they don't have chair to sit, they fall down. And very extensive surgery in the past. And still now, extensive surgery, but this is a new treatment that will have, these people might have a very thick ligament. We call it the ligament of flavum, and in front of the ligament may have a big disc, and supposed to be normal and round nerve like this, but because of the compression from the back, the disc from the front, the arthritis from the side, that disc, instead of round and round, become like triangular, very thin. And when it happens like this, it affects everything of patient. So there is a treatment called minimally invasive lumbar decompression, which is get into a spine, as I mentioned earlier, with a small opening in the back of the spine, and get there and just clean the area, the deposit of calcium, ligament, and bone, and bite those bones in the small pieces, get in and out, and clean those areas. I've done about 50 of them for the last 2 years, and we noticed a remarkable improvement of function and save patient from being debilitated. So those are a few options for spine treatment.
Excellent. We actually have Sarah back on the line. She's needing a follow-up question for you. So, Sarah, what do you have for Dr. Bell?
Yes, thanks for taking my call again. So I was wondering on that non-invasive surgery that you were referring to for the bulge disc, if that's a procedure that you do at your facility, or where exactly, whereabouts does someone go to get something like that done?
We'll be happy to visit with you regarding lumbar decompression and disc herniation. There is an option in my clinic that will help some disc bulging, and we would like to review the MRI and we'll discuss the possible outcome. As I said, there is a few options, including lumbar decompression, also discectomy, and also endoscopy. And there is also open surgery. So the most important is physical examinations, MRI findings, and we can go from there.
Excellent. I'd like to talk a little bit, we're just about out of time, but I'd like to talk a little bit about migraines and what you can do to help someone who suffers from that.
Migraine is a very common issue. There is migraine, just migraine, and there are migraine that is related to a cervical spine. Those are what I see the most in my clinic. People with headaches that's coming from the back and around the skull, and it's just very painful, sleep at night or so on. Those are headache related to spine. We call cervicogenic headache. We can find out with the diagnosis tools testing. We can inject the nerve that is called the great occipital nerve, and it can relieve the headache almost right away. There are migraine that will be a variety of migraine. We can paroxysmal hemicrania. There are migraine that is with aura, all of that, different kind of migraine from male to female. And those can have a very specific treatment from what cause. Some of the treatment of them can be verapamil, sometimes oxygen, sometimes tryptophan, different kind. Some can be just with TCA or medication antidepressant. The most important is to have a question and evaluation to find out what type of migraine this person has and how many of migraine does this have in a week, in a month, and what type of attack this person has. Some people start with just visual changes and then followed by attack of migraine, and some of them is just one side of the head, some of them both sides, sometimes start with one side and become both sides. So it's a good question. If it starts to be chronic, happening often, start with primary care and then being seen by specialists later on.
Okay. Thank you very much for being our guest tonight, Dr. Bill Razafindrabe from Great Bend. On our next Doctors on Call, we'll be discussing obesity and weight management. You can email questions to us for our next program at doctors@shptv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from Gove County Medical Center in Quinter, healing through caring. Blue Cross and Blue Shield of Kansas, serving approximately 950,000 Kansans in various programs. A value Kansans trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Russell Regional Hospital, experts, neighbors, friends.